Good evening and welcome. Welcome. Thank you for coming. My name is Emily Baker, and I serve here as a health professions advisor. For those of you that are not from the Hope community, we welcome you here to Hope. And we are here because of a partnership that Hope College has with the Michigan State College of Human Medicine, where we get to engage in conversations about health-related issues that affect community members. And we're grateful to hear tonight from Dr. Nykamp about behavioral health. But first, I'd like to introduce Mark Brevy as the Director of Government and Community Relations from the College of Human Medicine.
Thank you, Emily. And as Emily mentioned, my name is Mark Brevy. I'm Director of Community and Government Relations at Michigan State University College of Human Medicine. We do really appreciate this partnership that we have between MSU and Hope College. We've been doing this Your Health Lecture Series event here at Hope for at least the last 8 years. I always enjoy coming back to Hope College because I'm originally from the Holland area. I went to that other school in Grand Rapids, Calvin. But both great schools, and both schools are early assurance program partners to MSU. With that, I would like to note that at the conclusion of Dr. Nykamp's presentation, he will answer questions from the audience and those written in the Q&A for those that are joining us virtually. And I would like to go ahead and introduce our speaker this evening. So Dr. Louis Nykamp practices psychiatry in the Lakeshore area and is the residency program director for Pine Rest. He provides outpatient psychiatry care at the Pine Rest Neuromodulation Clinic and at the Pine Rest Zealand Clinic. He is a graduate of Hope College. Come on, okay. And earned his medical degree at Wayne State University Medical School. His residency and fellowship were completed at Mayo Clinic in Rochester, Minnesota. Dr. Nykamp. Thank
you very much. All right, thank you very much. I understand the microphone is going out to the computer land. So I will have to try to project in here. Please let me know. My family's always telling me that I speak too softly. So I'm going to do my best to project here unmiked, but let me know, just give me a thumbs up or something like this, like if you can't hear me. But so Jan, we're good with this one? Yeah, okay, cool. All right. Well, it's great to be here. I very much appreciate the invitation. I really wrestled with figuring out what to talk about this evening, because the options were broad. And so what I have done is sort of encapsulated a fairly broad range of topics to talk about, because it's what we're going to talk about, some challenges facing behavioral health care, and especially access to behavioral health care. We're going to talk about some of the reasons behind those challenges, some of the underlying factors that are contributing to some of those challenges that we're facing in behavioral health care right now. And then I also wanted, I didn't want to leave that on a kind of a downer note, so I wanted to talk about some innovations also in behavioral health care, some things that are just new, exciting, I think represent some areas for really interesting further exploration, and could potentially have be very impactful in terms of caring for patients with behavioral health care needs. So, as Mark mentioned, yeah, I work at Pine Rest in Grand Rapids, and I've been there for about 17 years. I do geriatric psychiatry mostly, so I work with older adults. I do a lot of dementia care, also work with patients who have Parkinson's disease, and I work in our neuromodulation clinic, which is our ECT, electroconvulsive therapy clinic, and also TMS, or transcranial magnetic stimulation. And I'm going to talk about those things a little bit at the end. And just tell you more about those. I also have had a couple of administrative type hats. Right now, I'm the director for our residency program at Pine Rest. That's been really rewarding. I've been in that role for about 2.5 years now. We just yesterday concluded our all of our admissions or application interviews. We did 120 application interviews over the last about eight to 10 weeks or so. Just got done with those yesterday, so we can take a big sigh of relief and kind of start over again in a few months. So I know that there's a number of people here in process of making applications to the first stage of that and getting into the medical school application process. And just really wish you well. I can tell you that coming out of Hope, my own experience was, and I know a lot of friends also who I went through med school with and have met since, feel like they were, I felt like I was really solidly prepared coming out of Hope to head into med school. I know there's always some sort of insecurity about that, like, am I going to be ready? Am I going to be able to handle it? You'll be fine. So shoot for it, and best wishes for your application. So I'll get into it here. I set up a few learning objectives. What I'd like to talk about are several societal forces that are impacting access to behavioral health care right now. And we'll look at that in also just through a lens of how might those be differentially impacting people of different ages as they're trying to seek out mental health care. It's not easy to find or to access. Once you're in the door, actually, the access is pretty good. But in order to be able to go from need, a time of crisis, to being able to actually access getting into an office with a psychiatrist on an outpatient basis, it can take quite some time. It could take many weeks or even several months. So we're going to talk about some of the forces that, and in the setting actually of child psychiatry, that can take, even out to 3 to 6 months time. So yeah, that's a, sorry, grab some water while I'm trying to project. So we're going to go through some of those, and then we'll get into some of those innovations that I was talking about. So first, let's look at some of the societal challenges for accessing behavioral health. All right. Really, what we've run into, and of course, especially in the last few years, of course, with all of the pandemic-related societal issues and concerns going on, a lot of the churn that has resulted in, both during the pandemic and some of that still post-pandemic, essentially aftershocks of that. We're still looking at a substantially increased demand for behavioral healthcare services. So that's the first thing that we're going to look at is where is this increased demand, and what is, how big of an increased demand have we actually been seeing? Interestingly, before the pandemic hit, pre-pandemic, most people, when they did surveys of adults, whether they're reporting symptoms of anxiety or depression, it fell at about 11% of people would report that. For those of you, I don't know if anyone from the psychology department here? Okay, very good. Anyone else? All right, excellent. So some of the screeners for depression and anxiety, the PHQ-9, the GAD-7, Generalized Anxiety Disorder 7-item scale. So that there's also the PHQ-2 and the GAD-2 that are screening devices. These numbers are taken off of those using those scales, done in really by like census taking agencies. And when they call homes and they're asking census related questions, they throw in those screeners in there. So that's how they're figuring out these numbers. And so before the pandemic, about 11% of people were endorsing either symptoms of anxiety or depression. And that went up to 40% during the pandemic. Since then, you'd think, oh, everything kind of fell back to normal, but those numbers haven't fallen back to normal. Last year, they were around 33%, and then I'll show you this year, they're around 32%. So we're still at a lot higher rates of just general survey, taking a slice of adult census from across the country. We're still at very high levels of people reporting distress, reporting anxiety and depression symptoms. You can kind of see here, this is by state, and Michigan kind of, I don't really know what to make of this one, but obviously this is in this territory here, that represents very high rates of people endorsing either symptoms of depression and or anxiety. In those states, the darker states, Michigan kind of falls a little bit less than that. The darker blue then are in the 30 to 34% category. 27 to 30% category is about where Michigan falls. So and then this is actually an active map if you look up this website, but the Michigan's was right around 29%, somewhere in there. So, we're still at much higher levels than pre-pandemic in terms of people endorsing some symptoms of depression and anxiety. So that has contributed to quite a bottleneck still in accessing behavioral health services. One of the other elements that has been contributing to that is just a general shortage, and this was true even before the pandemic hit, of behavioral health care professionals, and especially in psychiatry, a relative shortage of psychiatrists nationally. And now there are little pockets here and there where you see more or less in terms of psychiatry kind of congregating, and I'll show you a map of that too. But but this has been a problem even prior to the pandemic, and now when we've got upwards of triple the need, essentially, we're at a time when we're still in shortage mode related to the field of psychiatry. And what's the deal with that? Psychiatry, I'm sort of biased. I like psychiatry. I don't know why everyone doesn't go into psychiatry, but what is this a result of? Actually, it's kind of this is part of the problem. Looks great, right? But part of the problem is psychiatrists as a whole are kind of an older group who are in the process of retiring. They're retiring to the beach somewhere down in Florida, or they're retiring down to Arizona, or just plain retiring. This is a very interesting stat looking at that. So if we look at the field of psychiatry, and actually, so the percent of practitioners in this field that are over the age of 55. Now, this field, pulmonary disease, you think, wow, 90%. They changed the name of that field. It's now pulmonary critical care. So people who are actually pulmonary disease practitioners, that field doesn't exist anymore. The only people still categorized under that field are over the age of 55 because they changed the name. And then kind of the same thing happened with preventive medicine. But you can see psychiatry is right, and then in terms of active practitioners in the top tier of people who are in the process. Pathology is one as well that not that many people are going into, but lots and lots of folks that are currently practicing psychiatrists are over the age of 55. So in the next 10 years, instead of an upward curve of like we've got more availability, more access, there's less. We've got people retiring out of the field. So I will point out too that it's a little bit different in the field of child psychiatry. So child psychiatry, only about 44% of the current practitioners in child psychiatry over the age of 55. So a little bit younger on the whole. I will say in our own residency program, child psychiatry has been a very, very popular fellowship. And so lots and lots of our class goes into child psychiatry, which bodes well because you'll see some shortage numbers in a minute that field is really, really short staffed at this time. So I just wanted to bring this up too on the theme of retirement. When I was looking into this, this popped up on my feed, and so Medscape 20 best places for doctors to retire. Anyone recognize that? Where is it? You can shout it out if you know. It's at Grand Haven. Yeah, it's the Grand Haven Pier. So Grand Haven is like number 14 or 13 on the list. So lots and lots of physicians are going to be retiring to Grand Haven, evidently. So at least this year it made one of the 20 best places to retire. All right. Now, I mentioned a little bit too that this hits people differently at different age groups. So the access problem is more acute for older age and for kids. It is still, there's a great deal of shortage for general adult in between, but there's more of an acute shortage for the extremes of age. So for kids who are needing to access care and older adults who are needing to access care. And that partly just has to do with, how many people are working in those fields. So, and I'm also going to include addictions in here as well, because that really covers all of the age groups, and also we're just getting past the pandemic, but we're also still in the throes of the opiate epidemic, right? Where there's just lots and lots of addictions care that's needed in the communities. And that really needs to be an area of emphasis right now, and in the care, in terms of the access to that kind of care being provided. But I'll show you some shortage numbers for addictions as well. So for general adults, there's just over 40,000 psychiatrists in the US. But you can see there's quite a few counties uncovered. So there's only psychiatrists in about 45% of the counties in the US. And so access to care can be really difficult, and especially in more rural areas. I'll show you on the map later, just some real difficulties if you're out in rural areas, or even some states that just have very, very few practicing psychiatrists at all. And primarily the psychiatrists that are out there practicing there's big collection of them up in the Northeast. It's pretty well covered up in the Northeast, and then out west. So you got the coasts kind of mostly covered from a psychiatry standpoint, but a lot of gaps in between. And I'll be able to show that. I'm more of a visual kind of person. I'll show that to you on how that breaks down on a map here in a little bit. So that's adult psychiatry, general adult psychiatry. Now for child psychiatry, if there are some figures that suggest that maybe 20%, this sounds a little high to me, but 20% of kids have a potentially diagnosable, treatable condition. That doesn't necessarily mean that everyone needs medications, but therapy work especially can be really, really helpful for kids. And a lot of this relates to anxiety disorders and ADHD and those kinds of disorders that can be part of just child development. And there's just a real chronic shortage of being able to get into child and adolescent psychiatrists. 41 states are ranked to have severe shortages by the American Association of Child and Adolescent Psychiatry. And you can see that they have 1 to 17 psychiatrists per 100,000 kids. And then 9 states on top of that, so that's the rest of them, have high shortages. So there's only one place in the country where there seems to be plenty of child and adolescent psychiatrists per 100,000 kids, and that's in Washington, D.C., and I have no idea why. You can interpret from that what you will, but evidently the capital is well covered with child and adolescent psychiatry. Now, geriatric psychiatry, that's sort of where I live. There's very few of us. There are not very many geriatric psychiatrists. I keep telling the residents that get to choose what fellowship to go into, go into geriatric psychiatry. This whole population, this bubble of the baby boomers is moving into this age group. It is totally job security for moving forward, because I've got some numbers actually showing that this group, well, right here. So by 2035, 78 million people are going to be over the age of 65. In 2020, that was 55. So we're going to have an additional over 20 million people over the age of 65 over the next, less than 15 years. So this is an area that's a real shortage area right now. There are only about 1,350 of us in the country doing geriatric psychiatry, with board certification kept up in geriatric psychiatry. And that's in the setting of, as you look at different disorders of aging, and you look at things like Alzheimer's dementia. Again, we talked about 20% in kids, but it's also 20% in older adults. may have a diagnosable and treatable psychiatric disorder. And those are most commonly personality disorders, anxiety disorders, some mood disorders as well. But then also just this potential group with Alzheimer's disease is going to be a huge chunk of the population. Even right now, 6.7 million people with Alzheimer's dementia, and that number is just going to be growing, unfortunately, over the next 20, 30 years. So over half of the geriatric psychiatrists live in only 7 states. And so you can see this sort of split to the coast, California, New Jersey, New York, Pennsylvania, a little bit down in Florida. So, and then there are 4 that don't have any geriatric psychiatrists. So, if I was in Wyoming, I'd be lonely, but popular. So, and again, I said, talked about just a little more visual in this regard. This is by every county in the country. So you can see the distribution here, the degrees of shortage, essentially. So this is psychiatrists per 100,000. So 0 is the gray. There's a lot. And then the areas that are really well taken care of, relatively speaking, are these green. And you can see those are very few and far between. You got the coasts kind of represented and the little dotted areas through. We're not doing terrible in Michigan here. We're kind of falling in kind of in the middle of that, in the middle of the mitten. But you get up into the upper lower and then the good chunks of the upper peninsula. And there just really is just a shortage of being able to access psychiatrists. So what about child psychiatry? And you'll be able to see the progression. So a lot of color still in this one, a little less in this one, and you can just see those shortage areas grow. So this is for child psychiatry. And you can see how sparse that is actually, and how much need there is for more child psychiatry expertise. And then I'll just show you, this is for geriatric psychiatry. And I thought that I was lonely as a geriatric psychiatrist, but if you look at board certified addiction psychiatrists, that's it. Now, because about 7 of my friends and colleagues are board certified addiction trained psychiatrists in Kent County, we actually look pretty good right here, Kent and Ottawa. But that's literally because I've 7 friends on Pinehurst campus who are fellowship trained addiction, board certified addiction psychiatrists. And the thing is, if you're in positions of advocacy and you're hearing about things like the opioid epidemic and how all of these funds need to go to that, which does need to happen. It needs to have some really good support to be able to do that important addictions work. There's a lot of work to do. We have a long ways to go to be able to get there. Now, there is some help on the way. Between 2016 and 2021, admissions into psychiatric fellow or residency programs were up 26%. So that's a really great trend. And we just want to keep building on that because we need more hands on deck. We need more people to help out in that field. We need more collaborators in that care, more nurse practitioners, more physician assistants, more counselors, more therapists. That is really necessary to be able to meet this need. So there is some positive there, and also it's a nice thing that where people train is where they tend to hang out to some degree, and especially in the setting of child and adolescent psychiatry, but also general psychiatry. So I think we feel really lucky to have a successful residency program here in West Michigan. Also Western Michigan University down in Kalamazoo has a great psychiatry residency program. And of course in East Lansing, the psychiatry. So it's lucky that we've got a pipeline anyway, and people at the rate of about 55 or 57%, people tend to stay where they trained or somewhere in the vicinity. So that will help us out locally, but we still need folks to, like I said, more hands on deck. And then I want to just touch a little bit on the reimbursement realities. And that kind of drives some of these other things, like choice of what specialty people are going to go into and what they're going to do with their career. These are some reimbursement realities. And the first thing that big pick now in terms of just where does society put its resources? And, you know, we talk about the opioid epidemic. We talk about the need for resources for mental health care to improve really everything. That's really what part of what I like about being in mental health care is it really relates to quality of life. I mean, you can, it applies in every aspect of health. That if you're struggling, for example, with depression symptoms, anxiety symptoms, thought disorder, bipolar disorder, you know, anything else, you can be really, really healthy, but otherwise, you know, otherwise physically healthy, but boy, life can be really, really rough. So this is part of the rewarding part of why I really like doing the work that I do, but it's also frustrating because there is a lot of lip service out there about society and how we have to support these things. But you don't have to look back very far. This is the Eastern Michigan Asylum. This was in 1876. This is a palace. Look at the size of this place. And the scale and the scope, and it's beautiful. I mean, it's ornate, sort of Gothic like this building is. This was the state of the art of behavioral health care in 1876. Now, granted, at this time, we didn't have any treatments. They didn't know what to do for folks who were suffering at that time. We actually have tools now. We can help folks. You know, we've got medications, we got therapies, we got, and I'll talk more about the incoming tools. We could do something now. But this is how society said, you know what, we can't really do much, but at least we can try to safely take care of people and house people. And not that condition, I mean, you know, usually when people talk about the asylums in the old days, they're talking about how horrible the conditions were. They're at their wits' end. I mean, people sometimes are with thought disorders. I mean, most, and I've always tried to mention this too. Most people with, you know, schizophrenia, schizoaffective disorder, thought disorders are not violent. That is not part and parcel of severe mental health problems. But there is, you know, there's enough of that at the very fringes that, yeah, sometimes the conditions in the asylums, they didn't know anything. They didn't have anything else to do. They had to maybe, you know, put people so that they couldn't scratch their eyes out, or they couldn't scratch other people's eyes out, and that kind of thing. So yeah, not great conditions because we didn't have the tools that we have today. But this is what mental health care looked like in the late 1800s. And then less than 100 years later, we're like, oh no, we got to empty these institutions, you know. And that was only like 10 or 15 years actually after we had the first medications, the very first medications to be able to treat mental health issues. 1949 was lithium. Early 50s, we finally got Thorazine. And you know, and then it just kind of blossomed from there. And we'll talk about a couple medications today that actually were discovered very early on, and now we're looking at them again 60 years later. But you know, finally we had like 2 tools. Oh, we can help now. And then the whole societal push shift, like, oh, we got to empty these places. And what we're going to do is we're going to take care of people in their homes. We're going to make sure that we have these surrounding services, these enveloping services, these teams that will go out and just take care of people in their homes rather than being housed, rather than being cooped up. That was what was sold. Here's what happened, right? So we emptied the large psychiatric hospitals, and people largely with serious and persistent mental illness, some of them landed in homes, some of them are in adult foster care, some of them are housed, but lots and lots, a disproportionate number of people are just displaced. They're either here or here. And the jails have become the de facto asylum. That is where where the prisons are at today. So, you know, I would love to see us get back to here along with the tools that we have now, because then we could really make a difference for people. You know, yeah, rebuild the asylum? Sure, if it looks like that. We need more buildings that look like that now. But not here, right? Or here. So you know, that's sort of the broader societal changes that started to really change in the 60s. Like, oh, we gotta, you know, the people need their freedom and they gotta be out there. And we gave them freedom, but well, sort of this side, I guess, but not so much here. So I really as you're going out into careers and as you're advocating for things, the community mental health, the systems that are in place now, they do valiant work. They are swimming upstream. So you know, their funding needs to be improved. They need more staffing. They just need, you know, more to be able to take care of more people. If we're going to take care of people outside of a big hospital setting, and we're going to try to do that in their homes or in foster care kinds of settings, there's no replacement for bandwidth of people, for teams to be able to do that. So hats off to the current CMH system, community mental health system. I think like I said, I think they're doing valiant work, but they really need more help from a resource standpoint. Also, just in general, Medicare, which of course covers most people age 65 and older, and also people on disability with Medicare benefits. So this has stayed flat. The Medicare reimbursement has stayed flat now for many, many years. And in fact, so last year there was a 2% cut, which doesn't sound like a lot, but then this year there's a 3.4% cut. And you can see the inflation index here, you know, recognizing that your practice costs and everything else in the world is going up and up and up with these inflation numbers. But Medicare across the board is doing cuts. And that's kind of, that makes it difficult to the extent that if you adjust for inflation, that Medicare reimbursement for medical care for these groups, for the disabled groups below 65 and then age 65 and older on Medicare, is actually down 26% over the last 20 years, if you adjust that for inflation. So, you know, got to make that dollar stretch. Things have not gotten less expensive in terms of how you have to practice medicine. They've gotten quite a bit more expensive. You need more teams, more people. You need billers. You need people who are, you know, out after. You need the business side of the house, and there's so medicine has not gotten less expensive to practice, but the reimbursement is down a fair bit. Now, I'll just show this visually because you can see that that reimbursement has stayed pretty flat as corrected for inflation. Practice costs have done this, and then prices for people overall, like inflation in general, that's this line. So you can just see that disparity just continues to grow. Now, within that, fortunately, for behavioral health, there has been some recognition in Washington about, well, you know, it seems like there's a lot going on from a behavioral health standpoint in the country right now. Maybe we'd better allocate a little bit more resource to that. It's kind of a zero-sum game because if they give some a little bit more here, they have to take it from over here because they're trying to stay budget neutral with the Medicare system. And but it's not for behavioral health care, it's not all losses. Medicare has been willing to continue to pay for some telehealth services, and we're going to talk about that a little bit more in a minute. They've allowed a little bit more leniency in how the care is supervised, like you can beam in on a Teams or on this kind of interface for supervising a resident, let's say, and then so yeah, some additional provisions for telehealth. You can get a little extra in your billing if you have shown in your primary care visit or just wellness visit that you've asked about, you know, are you having any stressors going on in your life? Are there any things that are, anything that's going on that has been, you know, really tough for you? Did you lose a job? Did you, you know, have you had other losses going on in your life? You can bill a little bit more if you tag that in there. It also expanded who can be an eligible provider under Medicare too. So there have been some gains there in the reshuffle, but overall, that's an area too that has continued to sort of clamp down and provide some, create some limitations in terms of bandwidth. So what are we going to do about that? And here's where I wanted to get into some of the interesting future aspects of things that I think that are on the near horizon, aside from we just need more people, right? We need more people in the field. We need more well-trained people in the specialties, doing geriatric work, doing addictions, doing child. Need that across the board. But but these are just some things that I've seen coming. I've gotten to watch these things start to happen over the last 5 to 10 years in the field, and I think, okay, this might lead to something. I think there's some promise here with some of these interventions. So pharmacologic strategies, these are not new medications, right? Psilocybin's been around a long time. It's just in a mushroom. So you may have been seeing a lot of newspaper headline, magazine headlines, and stuff online about, oh, what about mushrooms and hallucinogens for psychiatric treatment, which kind of sounds crazy. There was these really all sort of peaked back in the 50s and 60s, and then they were all placed on Schedule I, made illegal. At least the psilocybin and related back at that time, and for good reason. But now we've got a little bit more sort of nuanced look or nuanced way to be able to look at these compounds and to see what they're actually doing and to know what receptors they're working at. And so that's giving us some hope that we might be able to use some of these things. And then the other one is ketamine, which is an old compound that I'm going to talk about in a little bit too. So ketamine, psilocybin. Let's do ketamine first. Ketamine was a compound that started out first. So this was at actually in Park Davis, which had a place in town here in Holland. Park Davis was just on the north side. If you cross the bridge, look to the left. That used to be the Park Davis plant. They made Benadryl there, among other things. So they invented Benadryl actually. But they also invented PCP. Back in the early or mid 50s. That was pretty wild when they tested that on patients, and it was very unpleasant. So they went back to the drawing board and created ketamine, which is a synthetic variant of PCP. And that actually worked quite well. It was first used for anesthesia by a couple of University of Michigan docs. Sorry, I gotta say that softly because I'll just mumble it. University of Michigan doc. In Ann Arbor was the first run of using ketamine for anesthesia back in 1964. This is the Park Davis, the main Park Davis headquarters on the Detroit River, and actually this was back in 1965. So it was right after they did that first administration of ketamine. And what gets me about this is that this back in 1965, that was Park Davis's 99th annual report. I didn't realize that they were that old, but there have been a lot of studies looking at the use of ketamine and ketamine infusion and ketamine variants for the treatment of depression. It does have, in some people, pretty rapidly antidepressant effects, very rapidly. And I've worked with it. We were part of a multi-center trial looking at ketamine and in ketamine infusions and looking at inflammatory biomarkers in their bloodstream before and after ketamine infusion. And it was really surprising to me, remarkable. People would, and it didn't work for everybody. I'd say, maybe between a third and a half of the people that were in our particular arm of this study came in. We would give them an infusion. It would last about 60 minutes, and they came in severely depressed, very down, would hardly make eye contact with you, very close, shut down, closed off, very, very negative, inwardly focused. And they would come out and they'd smile and they'd crack a joke, and it was amazing. And so there's promise with this. There are some places, we're not right now, but there are places who are utilizing ketamine clinically. My own feeling is that really is best done under the umbrella kind of a broad range of psychiatric services, a lot like we use ECT or TMS, like I'm going to talk about in a minute. But there's a lot of promise there. This is a whole new mechanism. We've heard about SSRIs, serotonin reuptake inhibitors, Prozac, Paxil, Zoloft, Celexa, Lexapro, Luvox, Effexor, Surzone, Pristiq. It keeps going. Trintellix. So SSRIs, we have dozens of SSRIs, serotonin reuptake inhibitors. They came on the scene in the 1980s. They've sort of dominated everything since then. This is the first new mechanism in a really long time. Looking at how ketamine works in the brain. I think there's a lot of promise with that. Just new variants, new molecules, some new ways of approaching brain chemistry to really try to help with some of these symptoms of depression especially. So there are two ways of administrating ketamine. One is by infusion. So if you're actually using ketamine, it has to be by IV. It's about a 60-minute infusion or so, and is very well tolerated. Sometimes people say they feel a little floaty, a little goofy. They can feel a little dissociative. It's called a dissociative anesthetic. We do not give anesthetic doses for the treatment of depression. People are wide awake throughout that infusion. They're just kind of relaxed. They usually sit in a recliner and then have the infusion. The other FDA approved administration of, so this isn't FDA approved. Nobody's probably going to get it there because it's been around since the 60s. And so there's no money in getting it FDA approved. So nobody's going to pick up the baton and say, oh, I'm going to get ketamine approved for use in depression. That's not going to happen because there's no patent life left on it. So what happened was they took it through one additional step of refinement and went from ketamine, which for the chemistry folks in the room is the mixture of enantiomers, the RNS enantiomers of the molecule, and then they went to just S-ketamine. So they were able to purify it one additional step, sort of like they did with Celexa and Lexapro. Same deal, but they did it with ketamine and put it in a nasal spray. So that is FDA approved and for the use in severe depression. It's unfortunately right now very expensive, but it is accessible as a potential treatment for very severe depression. So I think these show some promise, and even if not these particular compounds, related compounds and the knowledge that we'll have of the neurochemistry based on the response we're seeing with these compounds. Other compounds I mentioned already, the magic mushrooms. I don't think there's a lot of sort of zealots out there right now, like, yes, let's finally bring back the hallucinogens and kind of 60s leftovers. And, so there is some of that, but actually it's another one of those deals where there is some promise with these compounds. There is some evidence that use of specific dosing of, in this case, psilocybin, can be helpful for pretty rapid resolution of depression symptoms. And again, this is one where it's brand new, it's new chemistry. These are serotonergic agonists, so they are they're going and hitting the serotonin receptor, the 5-HT2A especially receptor, but then there's a whole variety of receptors that they hit if you go on down the line. But these are all these hallucinogens that are out there, and they've been Schedule I for a really long time, so they've been like, no touch, no research done on them, but finally there's some research cracking open, looking into this and showing some promise. So I'm hopeful about that. Not about necessarily, I don't think it's going to be a magic bullet. I don't think they're actually magic mushrooms, but I am hopeful that at least we can learn about some of the compounds in here and start to work with different brain chemistry from the SSRIs, which we've had for several decades. And you can see that these compounds are gaining interest. This is just the number of publications in PubMed over the last few years, and you can see like back to 1961. So nothing, blip, nothing, and then lots of interest in these compounds now. So I'm optimistic about that. This is going to lead somewhere and get us to some additional tools that we can really help people. The other thing I wanted to just mention, see where I'm at time-wise. Neuromodulation techniques. And a lot of times when I say, oh, I work at the Pine Rest ECT clinic, And people are like, what? They still do that? And and I got to do this because show of hands, there's going to be there probably will be a split. Like for so many years, it was like, oh, you mean like in One Flew Over the Cuckoo's Nest? But so show of hands, who has seen One Flew Over the Cuckoo's Nest? All right, so we have a few. We have a few. Okay, so old Jack Nicholson movie. Actually, great movie. I'd recommend it. You know, if you're really bored, and you know, I'm sure it's probably free on Amazon Prime, whatever. But but it showed Jack Nicholson in a psychiatric hospital, essentially, you know, getting punitive electroconvulsive therapy applied. That is not how ECT is done, but. Yes, we still do. ECT started in 1938. It was by two guys from Italy, Lucio Bini and who's the other guy? Anyway, two guys from Italy who were just trying to find new ways of intentionally inducing seizures in people. And because they had observed that sometimes if somebody had a seizure, they seemed to be better after their seizure and displaying kind of sometimes severe symptoms of whether it's depression, anxiety, or thought disorder. Pre-seizure, then they'd have a seizure, and then they'd seem better after that. And so, well, is there a way that we can induce that? And so ECT was invented in 1938. It actually spread pretty quickly because at that time there were other things happening in Western Europe that a lot of college professors and physicians and people were hopping off of that continent and going other places, going to North and South America in order to avoid everything that was brewing in 1938 Europe. And so it came to the U.S. pretty quickly and started practice in about 1941 or 42. Is when at the APA meeting, so the American Psychiatric Association had a live demonstration of ECT at their 1941 or 42 conference. I think it was in New York, but it remains the mainstay gold standard for very severe treatment-resistant depression, especially depression with psychotic features, catatonic features. It works exquisitely well for that population. But it comes with, it's very common to have side effects of you're having treatments. Actually, an acute series of ECT looks like you're getting treatments Monday, Wednesday, Friday, so usually 3 times a week, and usually for 3 or 4 weeks. And then oftentimes we'll continue after that for a little while, just because that first month or two after you've done really well with an ECT series is the most susceptible to relapse. And so a lot of times we'll stretch it out. We'll continue to do some treatments over the next few months and then sort of taper it out at the end. But people can do really well. We see upwards of 70–80% response and remission rates with ECT for very severe depression symptoms. But from a side effect standpoint, people especially during that time of getting ECT treatments, induced seizures 3 times a week, they just feel foggy. They feel like their memory is spotty. They get, a month out and they look back and think, well, I don't remember, much of the month of December. And well, that's normal. It doesn't cause lasting harm to memory centers. That's been shown pretty well. But yeah, people can have periods of time that just feel quite foggy to them. So from a cognitive standpoint, and just the logistics involved around it, it involves general anesthesia, albeit brief, about 5 minutes under general anesthesia with each treatment. There's a lot of logistics around ECT. So, can we do something that helps to keep the great effects that ECT has, but minimizes all these side effects and surrounding logistics about having to, have a family member drive you to and from and sit with you after the treatment because you've had general anesthesia. There's another way of eliciting seizures called magnetic seizure therapy, and that is using, well, just what it sounds like, a very powerful electromagnet. So instead of actually using what is for ECT a very small current, just pulsing back and forth to get enough neurons firing together to generate a tonic-clonic seizure, you can do that with an electromagnet and just pulse this electromagnet, and it induces current in the brain itself and induces enough current in the brain so that a seizure happens. What we see with that is that you have less cognitive side effect with that as compared to electroconvulsive therapy. But this is still in the very much in the research stage. It's not used in a clinical way at all at this time. But then the last one here is called TMS, transcranial magnetic stimulation. This is very interesting because it also uses an electromagnet and placed on different parts of the brain in order to activate certain areas of the brain to achieve outcomes that you want. And so in the setting of depression, for example, for transcranial magnetic stimulation, you're seated in a chair. It looks kind of like a chair in it's not maybe the best thing to associate it with, but it looks like a dental chair, or I guess we could let's call it like a spa chair instead. But you can see there's an electromagnet. You just place it against the head. You pulse it in a certain way, and the area of brain that's underneath it, you can get about 2-3 centimeters of distance penetration, so you can get to the cortex, and you stimulate that area of the cortex, and start getting some patterns of activity passing through that cortex that normalizes activity from more of a depressed phase to more of a normal euthymic phase of operating in the brain. So it's TMS for clinical purposes has been around now for about 10 years. But what we see is we have a fairly busy TMS clinic along with our ECT clinic, and what we see is that this can be quite helpful for depression, and also minimal at all for any kind of side effect. Really, no side effect. You drive yourself to and from visits. You sit down. You have this thing pulsing for about 20 minutes, or we can shorten it to as much as 5 to 10, and then go back to work. It's really handy. It works well. But we would like to see it dialed in a way that is even more effective. The way that TMS courses are set up right now, the standard protocol is that you do 30 to 36 treatments. They're done on a daily basis. Usually we do it 5 days a week. We don't, just because staffing through the weekends is a thing. So takes about 6 weeks of treatment, or 6 to 7 weeks of treatment. It's a daily thing. To me, I don't have that kind of patience. It takes too long. It just takes too long. So so out at Stanford, they came up with the SAINT protocol, and this really hit the news about not last year, but late the year before. And they have this accelerated protocol where they take people in and they will give them 10 5-minute treatments a day, 5 days in a row, and essentially pack more than 6 weeks, more like 8 to 10 weeks of treatments in 1 week's time, because you're coming in every hour, you're getting your 5-10 minutes of treatment. You do that 10 times a day, and you do that for 5 days. And they had fantastic results with that. So I think that's really, really promising. And that's why I think we really have some tools coming to us that will be at our disposal to help bend the curve a little bit, to help improve the effectiveness of the treatments that we offer, and to be able to really start making more differences in how people are doing, and treating even treatment-resistant depression more effectively. So that's why I really think that there's more to come in this whole neuromodulation piece. We have another protocol for this, actually targeted at obsessive compulsive disorder. It's a little bit different placement of the electromagnet. Obsessive compulsive disorder is notoriously difficult to treat. There are some very good psychotherapy treatments to it that are related to exposure and response prevention. Those are hugely important to be engaged in for OCD. But also we have seen some success in using transcranial magnetic stimulation for the treatment of OCD as well, kind of in a combined way. So this is another modality I think that's really going to help us to meet that challenge. And then the last thing I'm going to talk about real quick and leave like a couple minutes for questions is just, what about new modes of delivery of care? And you know, if there aren't that many of us, and we saw all of those gaps, all of those gray counties on those maps, like how are those people going to get 10 counties over? Something that happened that we really got forced into in I think a very unexpectedly beneficial way with the COVID pandemic is into the area of telepsychiatry. And that has been able to get us into every county in the state of Michigan, where, now for our Pine West network, for example, we have lots of clinics around the Grand Rapids area. I've got one in Holland and just north of Grand Haven, between Grand Haven and Muskegon, down in Kalamazoo and Portage and Traverse City. And so a pretty good clinic network. But, even with that network before telepsychiatry, our footprint was a good chunk of the west side of the state and a little bit around in northern Michigan with the Traverse City Clinic. But now our footprint really is the whole state, which is great, including the Upper Peninsula with telepsychiatry. So this is something that allows us to get to people. I think psychiatry is uniquely suited for a telehealth type platform. There are things that we need to do as psychiatrists that do involve some physical exam. Some of the medications that we prescribe can cause some tightness in the muscles, can cause some Parkinsonian features, that kind of thing, and we need to check for that periodically. But really, telepsychiatry, we went from being about 0.5% of our visits annually, of 200,000 visits or plus annually in the network, 0.5% being telehealth, to 100% being telehealth in the third week of March of 2020. That interestingly has, everything's sort of back to normal, right? We're still 50% telepsychiatry. And it looks like we're going to stay that way. We settled at 60% for a while, and then it drifted down to about half. And I think we're going to stay there for the most part, at about 50% telehealth services. And so I think this is going to help force multiply at least our reach, right? Our geographic reach. The other models of care are these embedded care models, where the psychiatrist is co-located in the family medicine clinics. And so practicing in the family practice clinics, it's a great model of care. I got to do this quite a bit during residency, and it's super helpful because one of the main models of developing a psychiatry practice is you see lots of new people, right? You see lots and lots and lots of new people earlier in your practice, and then later on in your practice, you're kind of seeing mostly the same people throughout, and you're hardly getting any new people in. But in this embedded care model, where you're working with the primary care doc, you see them for a few months, or you see them for a year, and then turn them back over. The primary care doc sort of pass the baton, you pick it up from there. That's much easier to do, by the way, when you're actually in their clinic. One would think, oh, well, why didn't you just do that, anyway? But that isn't hard. That isn't easy to do unless you've got a relationship with that primary care office, with those providers, and you can hand patients back and forth, and they know that you've got their back. If somebody starts having problems, they can get them back in to see you in tomorrow. So that's a great model of care. And then there are some other models of care management where it's more like a population model, where there's a care manager at the primary care office. They keep a whole roster of patients who are having trouble, and they do a lot of scores, like the depression scales and anxiety scales, and the psychiatrist sits and looks at a bunch of those numbers and says, okay, I think this person needs, you might consider going up on your dose of Lexapro for this person, or adding buspirone for this other person. So that's another model of care to force multiply the relative shortage of psychiatrists that are out there. But so I think some of these modalities really are going to help address those needs. So we've covered the societal changes with the increased demand, the shortage, and then how that differentially impacts the different age groups. We've talked about the innovations that might help get us to being able to see more people with the telehealth, and actually treat more people successfully and more rapidly for depression symptoms. A couple new compounds promising in that regard. And that's where I'll land with it. Just about on the dot. Yeah. Thank you. Any questions? And it doesn't have to be about this either. If it's about like, it was a great discussion earlier with the med student panel. And so if it's a question about like med school, especially residency, because that's something that I know more about. I'm a little removed from the med school application process. Yeah, happy to anything. Sure. Great. Yes, thank you. So the question is, describe the role of psychiatry in the setting of Alzheimer's patients. So, as it happens in the context of whether it's Alzheimer's disease or any of the other neurodegenerative disorders, Lewy body dementia, vascular dementia, at some point along that progression, unfortunately, there often emerge various psychiatric symptoms. And so that can be along the lines of, for example, in fact, I was working on the inpatient unit this past weekend, and with somebody who was in the moderate to approaching severe stages of Alzheimer's, somewhat a little bit younger than the usual, and otherwise pretty healthy. But memory, and with Alzheimer's in particular, it's an early memory problem. The hippocampal structures start to deteriorate and be impacted or early on in Alzheimer's, and so it's a memory problem, especially early on. It can affect other things too: language, visual spatial function, executive function, judgment, all of that as well. But just to give an example, this was a person who just couldn't remember, if I saw him after lunch, he simply, it wasn't there what he had for lunch or what he even had for breakfast. And he was, he had a folder of things in it and showed me that that these things he didn't put there. He didn't put these things in that folder that he was walking around with. Somebody else did it. It was the gremlins. And so he had a very, very elaborate framework of beliefs that there was something going on in his house and something going on even at the hospital in a locked inpatient unit, that these gremlins were getting in and moving things. And so these sorts of symptoms fairly commonly accompany Alzheimer's dementia, and coming up with sort of paranoid descriptions of why things happened. The common one, right, is somebody's still at home, they've got pretty severe memory problem, and they're constantly calling 911 because somebody stole my bracelet, somebody stole my watch, somebody stole my, and then the police come and they knock and they come in and they find it in the freezer. So these sorts of things are just part and parcel of and also anxiety, depression. Those are common manifestations in the context of neurodegenerative conditions, and that not only with like the dementias, but also with Parkinson's disease, for example. So that's from a geriatric psychiatry standpoint, that's the niche that I usually provide care in. Any other questions? Well, thanks so much for coming out on a yeah. No, I appreciate it. Thanks for coming out on Tuesday night. Yeah, let's get close to this. Yeah.
So let's thank Dr. Nykamp one more time for coming back to his alma mater here at Hope College.
Hope.
And I'm sure he'd be willing to stick around for a couple minutes after the talk if you have any other questions.
Yeah, I'll be up here.
Thanks.
Yep.